Good evening, respected Professor Sir and Professor Subramani Madam and my dear students. I welcome you all to another session of RISA DNB online academic activities. Today we have a long case presentation by Dr. Prateek Shukla and Dr. Nandini. Over to Professor and Dr. Prateek Shukla.
Thank you, sir.
You can start.
Thank you, sir. Sir, case given to me is a 38-year-old Mason with history of alcohol abuse for last 20 years. Now comes with progressive distension of abdomen, swelling of legs, and has one episode of vomiting of blood. So to begin with, a 38-year-old married male from Kamrup rural, Mason by occupation, presented to ER with the complaints of decreased appetite since 1.5 months, progressive distension of the abdomen since last 1 month, swelling of both the legs since 1 month, single episode of vomiting, vomiting of blood today afternoon. So history of presenting illness, patient was apparently normal 1.5 months back, and then he starts to develop loss of interest to food, thus leading to loss of appetite, which is not yet associated with significant weight loss. One month back, he observed distension of abdomen, which was uniform and progressive in nature, and was present throughout the day, not relieved on lying down, and was not associated with pain, tenderness, shortness of breath. It was also not associated with fever with chills, nausea, or constipation. It was also not associated with hemoptysis or hematochezia or epistaxis. Along with this, patient also developed swelling in both the limbs since last 1 month, which was also progressive in nature, which initially used to resolve in the morning and progress as the days goes on, but later on it became persistent since last 25 days. There is no history of rash or itching throughout the body. History of single episode of blood mixed vomiting today afternoon, which consisted mainly of blood and some mixed amount of food. Amount was around 1 glass. It was a non-projectile, non-bilious vomiting. No history of head trauma or chest trauma. It was not associated with retching or shortness of breath. Past history of jaundice, mild grade 3 times in the past 5 years, which resolved on oral medication and temporary abstinence from alcohol. No history of hematemesis in the past, no history of hypertension, diabetes, tuberculosis, epilepsy, coronary artery disease, chronic kidney disease, no history of blood transfusion in the past, no surgical history. Personal history, a patient is on mixed diet with normal bowel and bladder habits, normal duration of sleep and normal duration of sleep cycle. He is habituated to alcohol since past 20 years, and he used to consume country liquor nearly 150 to 200 ml per day. No any history of IV abuse, intravenous drug abuse, no history of smoking or tobacco chewing. He has no history of allergy to any drugs. Drug history, patient is non-compliant for previous medication. So whenever given medication, he continues for a few days and leaves. Family history, no significant family history is there. General examination, general condition average with height of 166 centimeter, weight 56 kg, BMI coming out to be 20.6 kg per meter square. Lean built with poor nutritional status, conscious and oriented to time place person. Pellar present, icterus not visible, no clubbing, no cyanosis, no lymphadenopathy or parotid swellings, bilateral pitting edema in the lower limb present, no flapping tremors, no gynecomastia, no scratch marks, no loss of pubic hair. Vitals.
Before you go to the examination of the patient, could you
Yes,
not
sir.
sum up the history findings? And there are a few points missing in your history. Can you identify what are the points you have not asked the patient? Now, what are all the positive points? One, he has been an alcohol abuser for 20 years. Okay?
Yes, sir. Yes, sir.
And you have mentioned correctly the type of liquor he consumes, country liquor, and the quantum of liquor imbibed every day that has been asked.
Yes, sir.
Was there any attempt to wean him from alcohol? What was the treatment? Is it for jaundice or it is for de-addiction?
Sir, that was for just means to suppress the jaundice. He never
Jaundice.
attempted for addiction.
So that history is very important. Whenever a person
Yes.
says he has been addicted to alcohol for a long number of years, was there any attempt to wean him off or de-addict him from the alcohol? Did he get treated at any de-addiction center? Did he use any antabuse or other medications to stop the habit of drinking alcohol? Did he not ask that?
Yes, sir.
Because
Sorry,
those drugs can have a lot of interference with his regular physiology, is number one. Second thing, as he traveled any to endemic area from where he can catch the jaundice,
travel
any
history.
travel apart from his own native place, that history is very important.
Yes, sir.
Has he had any extramarital contacts?
No, sir, I confirmed that he's a married guy. Means,
Yeah, married guy doesn't mean that he should not have an extramarital contact, no?
yes, sir.
So HIV infection, that also has to be ruled out, because this kind of persons who are addicted to alcohol, they can have all sorts of habits.
Yes,
Okay,
sir.
so
Yes,
these
sir.
3 points you have to ask. One is any attempt to de-addict the patient. Second is, has he traveled to endemic areas from where he can contract jaundice. Third is the extramarital contacts, which is possible for him to develop a HIV infection also. Okay, so
Yes, sir.
these three to be added in your history taking, and every time when you complete the history, you sum up your findings in the history and make a probable diagnosis.
Okay,
And
sir.
you said he is vomiting blood. What
Yes, sir.
type of color was the blood?
Fresh,
Is it
fresh color.
fresh blood? Fresh blood means is it coming from the pharynx, or is it coming from the stomach or esophagus?
Probably esophagus, sir.
Esophageal variceal bleeding, will it be fresh like this, or will it be little altered? Because it will have to go to the stomach, and then from there only it has to come out. It cannot directly come from the esophagus. So whenever
Yes,
it goes to the stomach, it will react with the hydrochloric acid in the stomach, and it will become altered in color.
yes, okay, sir.
Okay.
Yes,
So
sir.
that is a very important distinguishing point between an upper GI tract bleeding and a bleeding in the stomach or in the esophagus. Okay, so
Yes,
that you must specifically ask, and you must ask the quantum of bleeding, whether he passed any, vomited any clots, okay,
okay, sir.
and was he hemodynamically unstable after that? Was he brought in a very critical state and resuscitated? All that history should be asked with the bleeding. It should not be just mentioned that the bleeding one episode. Every detail about the bleeding, the color, the quantity, and its impact on the patient's physiology, all should be documented. Okay. So
Yes, sir.
note down these 3 points which you have to ask in the history, and about the
Yes.
bleeding, about these 3 points: the color of the bleeding, the quantity of the blood, and the effect of the bleeding. Was it mild, moderate, or severe? And whether he was recovered after any treatment given for that when he came to the hospital. All that history should be documented. Okay, and then after taking this detailed history, you should sum up the history as to what could be the cause for this, because his primary complaint, he has come to the hospital, is an episode of bleeding.
Yes,
So
sir.
you must make a probable diagnosis with the history of 20 years of alcohol consumption, distension of abdomen, leg swelling. Probably this patient has gone on to a state of cirrhosis liver with portal hypertension, which could have caused esophageal varices, from which bleeding could have happened. So that is your probable diagnosis. That should be summed up in the history taking itself. Then you proceed
Yes,
to
sir.
the examination of the patient. Okay.
Okay, sir. Yes, sir.
So always make this habit of summing up your positive findings from your history before you proceed to the examination of the patient. Right,
Yes,
go
sir.
ahead. Now you can continue with the examination of the patient.
Yes, sir. So general examination. General condition is average with height 166 centimeter, weight 56 kg, BMI around 20.6. Lean built with poor nutritional status, conscious and oriented to time place person, pellar present, icterus not visible, no clubbing, no cyanosis, no lymphadenopathy or parotid swellings, bilateral pitting pedal edema present, no flapping tremors, no gynecomastia, no scratch marks seen, no loss of pubic hair yet. Vitals, heart rate 96 beats per minute, right radial pulse, regular rhythm with normal volume and character, no radio-radial, no radio-femoral delay, all peripheral pulses felt. Respiratory rate 18 per minute, abdominothoracic type. Blood pressure 100 by 60 mm of Hg at left arm sitting position. Temperature afebrile, saturation 99% on room air. Airway examination, no obvious facial deformity, mouth opening more than 3 fingers, Malampati grade 2, thyromental distance more than 6.5 centimeter, neck movements adequate, upper lip bulb test class 1. Spine examination, no visible gross deformity in the spine seen, normally aligned spine, no scar marks on the spine. Coming on to systemic examination, per abdominal examination, inspection in supine position with arms on side, abdomen is distended, umbilicus is inverted and central. All quadrants move equally with respiration. No visible peristalsis or pulsation. No visible hernia or divarication of recti. No dilated vein or scar marks seen. Palpation. No superficial tenderness or local rise of temperature. No rigidity or guarding. On deep palpation, lower border of the liver palpable in the right subcostal margin. Regular margin with firm consistency and moves with respiration. Kidney and spleen are not palpable. No renal angle tenderness. On percussion, liver dullness is present at right fifth intercostal space. Tympanic shifting dullness present. Tympanic node present paraumbilical and dullness is present at the flanks. Fluid thrill is absent. On auscultation, bowel sounds are present. No arterial, GUI or venous sound. Cardiovascular examination, JVP is not elevated. Apex beat is present at the fifth intercostal space. S1, S2 heard, no murmurs. Respiratory system, air entry present, bilateral, normal vesicular breath sounds. CNS, higher mental function and cognition intact, no focal neurological deficit. Sir, I have written summary here after this. I will put this before examination.
Again, you have to repeat your summary after your examination also. First
Okay,
summary after your history description. Second
Yes, sir.
summary will be whether your diagnosis made from the history, whether it is
Examination.
confirmed by your examination. So
Okay,
that
sir.
is the second summary. So
Yes.
during the second summary, you must substantiate what are all the physical findings which are contributing to the diagnosis you have made from the history. So are there any positive findings in the patient to confirm that it could be a case of cirrhosis with portal hypertension? Which diagnosis you have made from the history because of the history of alcohol abuse of long duration, the gradual distension of the abdomen, pedal edema, and now blood vomiting. All these things indicate that it is a case of alcohol-induced liver cirrhosis, probably with portal hypertension, producing portosystemic communication at the esophageal level, causing bleeding, esophageal variceal bleeding, which the patient has vomited as hematemesis, and he has come to the hospital.
Okay.
So what are
Yes,
the
sir.
physical findings after examination of the patient? You are able to contribute it to the diagnosis that you have made from the history.
Sir, first of all, he gives an history of loss of appetite, which is consistent with chronic alcoholism also.
That is history part, but now you must
With
pick out all the positive findings from examination of the patient. What is the pulse like in this patient? Did you describe the pulse, character of the pulse?
Sir, normal volume and normal character, but ideally it should be hyperdynamic, means in portal hypertension and liver disease patient it is hyperdynamic pulse.
Hyperdynamic. So you should specifically look for that, and if it is absent, you must say it is not the characteristic hyperdynamic pulse, but it is a normal volume normal pulse. Okay, that is one important thing which will tell the or impress the examiner that you are looking for such a change in the pulse. Okay.
Yes.
Why there is a hyperdynamic pulse in a liver disease patient or a cirrhosis patient?
Sir, due to splank,
When will you say a pulse is hyperdynamic or
Sir, large
volume?
large bounding volume of pulse is there. It is called
Ah.
as hyperdynamic pulse.
Yeah, why it happens? What is the change that is happening?
Sir, cardiac output increases in these patients generally because of uh, decrease in the systemic vascular resistance and uh,
The simple answer is it is an increase in the pulse pressure. Whenever
Yes,
you find the pulse is bounding and hyperdynamic, it is always because of the increase in the pulse pressure, which means the systolic pressure is high and the diastolic pressure is low. So
Yes.
instead of the normal 40 millimeters of mercury, when the pulse is BP is normal 120 by 80, the pulse pressure is 40. Whereas
Yes.
here there is a systolic hypertension and the diastolic hypotension. The systolic BP may be 140 or 150, diastolic may be 60. So there is
Yes.
a wide pulse pressure of 80 millimeters of mercury. So this is the
Yes.
reason mainly happening in all conditions where there is a hyperdynamic circulation or a bounding pulse. Okay.
Yes,
So
sir.
that is
Yes.
the answer that you have to give. The increase in the pulse pressure is the reason for the hyperdynamic stature of the pulse. Okay.
Yes, sir.
Right.
Yes,
So
sir.
that is what then what are all the other physical general examination findings is that the patient upper body look very lean and the lower body look filled up.
Yes, sir. Means lean build.
Poverty above and prosperity below. It's a classical description, isn't it? For
Yes,
the
sir.
patient with cirrhosis liver, it is called poverty above. That is above the nipple, the patient looks emaciated. The ribs are seen, the clavicle is seen, the shoulder bones are seen, and face
Yes,
looks
sir.
emaciated. Whereas below the nipple level, there is a protuberant abdomen. And you said there are no dilated veins or scars seen around in the abdominal wall. Where
Yes, sir.
exactly you will look for that? In case this patient had a variceal bleeding, where else he could have had a systemic communication, which will be very evident for
Sir,
inspection itself.
sir, in
What is the name for that?
around umbilical region, sir, that
Ah.
is called as caput medusa.
Caput
It is
medusa.
it is the
Ah.
protosystemic anastomosis of ligamentum teres along with superior epigastric vein or inferior
So
epigastric vein.
instead of saying no dilated vein seen, you must always describe in these cases there is no caput medusae seen.
Okay,
Okay,
sir.
so that will
Yes,
give a better impression to the examiner that you are looking for the presence of dilated veins around the umbilicus in the form of this
caput
photosystemic
medusa.
communication. Okay. Why it is called caput medusae?
Sir, Medusa means it looks like a snake coming out of a head. Means Greek goddess Medusa was having that appearance, because of that it is
Yeah,
known as.
caput means head. It is
Head.
has a headgear made of like looking like snakes. Okay, so you're right. It is a Greek goddess Medusa having a headgear like with all the snakes made around it. So it looks like that. So it is called caput Medusa. Right. So these findings with the abdominal distance, you said there is no fluid thrill. When will you get a fluid thrill?
Sir, in tense ascites, fluid thrill felt in tense ascites, sir, and means when.
What is shifting dullness?
Sir, shifting dullness signifies it signifies that mild to moderate ascites is there, which can, when patient turns from one decubitus to other decubitus position, the fluid shifts, and it is suggestive of it is mild to moderate ascitic fluid only, which is able to shift. So
Very
that.
good. Okay. Right. How will you detect a very small quantity of ascitic fluid?
Sir, ultrasounds.
When the patient lies supine, you find you try to see the shift and you try for the thrill. There is nothing seen. But
Yes.
there is a definite small quantity of fluid. If you have to clinically detect it without the help of an ultrasound or other investigation, how can you detect that?
So in pouch of
One of the
dullness,
surgery teachings, how they teach you how to detect a very small quantity of fluid The
Sir,
patient
puddle
can
sign,
take
puddle
Huh?
sign, sir. Puddle sign. Tell the patient to be in knee chest position and then around the
Exactly.
abdomen.
Very good. Excellent. So, your patient should be in the knee chest position or in the four-leg position. Then all the fluid will collect around the umbilicus, and if you tap there, you will get a dull resonant mode. It will not be
Yes.
normal resonance. So that is the way to detect a very small quantity of fluid in the knee elbow position, not knee chest, but knee elbow position. Okay,
Yes.
so that
Yes, sir.
you can bring all the fluid around the umbilicus and then do the tapping. So sometimes they may ask you all these clinical methods of detecting the fluid. So with all these findings, now we have come to the diagnosis that it could be a case of cirrhosis liver with portal hypertension with variceal bleeding. Now, how are you
Yes, sir.
going to manage this patient?
Sir, as patient has come into ER department, so initial resuscitation of ABC should be followed. Means if everything in circulation, and depending upon that means circulation means if he requires due to if he is hypovolumic, then we'll ask for a blood transfusion, or we should give crystalloids according to the blood loss assessment.
Okay.
Then once patient is stabilized, he should be shifted to ward, and then medical management should begin, sir. Medical management will comprise of drugs like beta blocker, means propranolol, sir, uh, means vasopressin or terlipressin drug, so that it can decrease the splanchnic blood flow, sir. Octreotide can also be used. Somatostatin octreotide can also be used so as to decrease the splanchnic blood flow and decrease the side effects of vasopressin or terlipressin.
Very good.
Sir, sir, short course of antibiotic should also be started in these cases.
Okay. All these things are is it a definitive treatment?
Sir, they are not definitive treatments, sir.
Mm.
Once patient is resuscitated and stabilized, then we should proceed towards endoscopic treatment. Means initially endoscopic treatment, which will include, sir, sclerotherapy, banding, or sir, balloon tamponade can also be done, sir.
Okay. Balloon tamponade through endoscopy or some other method?
Sir, earlier it was means we were doing balloon tamponade, sir, means, but it is not endoscopic procedure per se, but it is a temporary arrangement.
What is the gadget that is used for doing this balloon tamponade in the earlier days? This is historical interest. Nobody does it now. But some examiners are very fond of asking something which is not common as a part of history. So you must know what is the gadget that was used to produce this balloon tamponade.
Sir, science
Sense taken blood.
taken black
Taken more tube. It is called sense taken more tube. Okay. And it is nothing but a thick rails tube like thing with a balloon of 6 inches length, which will be positioned around the lower esophagus and between the lower esophagus junction to the fundus of the stomach, and you inflate it. So it will compress the peripheral veins and prevent the bleeding. But the moment you deflate it, there is a chance it can rebleed. So the ideal correct treatment is to go and either do a banding or do a sclerotherapy with a endoscopy. Supposing the medical gastroenterologist who wants to do this interventional therapy, he asks for anesthesia to give GA because patient is restless, not cooperative. What anesthesia you will give? How do you anesthetize the patient?
Sir, ideally, I will prefer a patient to be under means monitored anesthesia care, means topical anesthesia. First of all, I will prefer to I will counsel the patient and tell him.
See, if it is going to be done under topical, he is not going to ask your help at all. Most of the medical gastroenterologists, they ask the patient to swallow some 4% lignocaine and apply some jelly and start doing the procedure themselves most of the time, isn't it?
Yes, sir.
But if they specifically ask you that this patient is very uncooperative because he is a chronic alcohol addict, he is not cooperating and I am not able to pass my scope and you have to give some GA or accreditation for him to tolerate my procedure. If that is the request, how are you going to manage?
Sir, then sir, I'll proceed with general anesthesia with controlled mechanical ventilation, and I'll be putting tube to nasal intubation will be my choice of intubation, so that I can give the oral space to the.
Anybody else having any other idea about how to manage
You can
this?
put gastric LMA
Gastro LMA, excellent,
Yes, sir.
very good. So nowadays we have the option of putting what is called the gastro LMA, which is meant for this purpose. So there is no need for you to intubate the patient. Okay.
Yes,
So there
okay,
is
sir.
a new instrument called gastro. So that is the reason why this sort of questions are asked. But before that, what are the precautions you have to take? What is the difference between giving an anesthesia at the OT and is this OT procedure or it is
This is,
done
no,
in
sir,
the
it is a non-operating room anesthesia procedure, sir.
that is the
So,
first and foremost problem. So you must mention that it will be a NORA procedure, non-operating room anesthesia procedure. So what are all the precautions you will have to take if you are going to do a NORA procedure?
so first of all, I will familiarize myself with the surrounding where the procedure is to be taken. Along with that, I will ask for means I will take all my emergency drug and emergency airway cards, sir, and oxygen access should be there at that oxygen and suction access should be made accessible at that area.
Hmm.
And,
So we always teach you a mnemonic to remember all these points. SOAP-ME, SOAPME, isn't it? Suction,
yes,
oxygen, pharmacy, airway, pharmacy,
yes, sir.
medications, emergency drugs, all that. So go through that mnemonic and please read it again so that you will be able to answer that question within a short time without beating around the bush and saying the same points again and again. Okay, right.
Yes, sir.
But if and the most important danger is that it will be like a fish stomach. We don't know how much of blood has leaked out and it is present still in the stomach. So
Yes,
any investigation will help, which is available in the modern day, to find out whether there is a chance of aspiration while doing this procedure.
Sir, USG assessment can give us a guide ki how much amount of blood is there in the stomach,
Excellent.
sir.
So we can do an USG. You know the formula how to calculate the volume that is present in the stomach by doing ultrasound?
Sir, no, sir,
It's
sorry,
one of
sir.
the ASCII questions. Okay. So
Yes,
you
sir.
have to know the area of the antrum and then multiply with the shadow that you are seeing. I forget the formula, but there is it's available in the book. So you have to remember that formula to say how you will calculate the volume. So if it is less than 50 ml, it is safe. You don't have to worry about it. But if it is
Yes, sir.
more than that, it is better to pass gently a stomach tube and
Right.
then aspirate the whole thing and then proceed with that. Okay. So these
Yes,
are
sir.
all the points. And when you sedate the patient, which will be the ideal drug to sedate to pass the gastro LMA and allow the surgeon to proceed with the endoscopy.
Sir,
What drugs you
propofol,
can use? Propofol.
propofol or thiopentone, or means I will not go ahead with benzodiazepines and opioid, minimal benzodiazepine and minimal opioid I will use, sir. Because
Okay. Is the Dexmed safe in this
Dexmed,
situation?
Dexmed can be used, sir. Dexmed can be used.
Ah.
Remifentanil if available, that also I will
Yeah.
use.
So you can use that also. So these are all the drugs that you have to keep in mind. So based on the clinical scenario, these are all the points if you get a clinical scenario like this to manage. But majority of the time, the questions will be with regard to portal hypertension, cirrhosis liver, and patient needing treatment for either an incidental surgery, that is non-liver surgery, or the patient ultimately needing a liver transplant. These are the directions in which the question can go if you get a liver case in your examination. So you must be very thorough with all the basic anatomy and physiology of liver function and also the clinical scenarios which can happen where you may require to give anesthesia for a patient with an established liver cirrhosis. Now, the first common question is, when the patient's history gives that he is an alcohol abuser, how does alcohol cause cirrhosis in the long run? What is the mechanism?
Sir, alcohol.
Pardon? What is the pathophysiology in alcoholic liver cirrhosis? How does it cause liver cirrhosis? Are you able to hear me?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Okay. How is alcohol consumed by a person is metabolized? First and foremost, the basic thing.
Sir, metabolization of alcohol is by alcohol dehydrogenase enzyme to acetaldehyde. Then acetaldehyde is further metabolized by aldehyde dehydrogenase enzyme, sir.
Aldehyde dehydrogenase converted to what? Acetaldehyde to acetate.
Acetate,
Okay.
yes, sir.
So,
Yes, sir.
so these are the two important enzymes: alcohol dehydrogenase and aldehyde dehydrogenase. Okay.
Yes, sir.
So
Yes,
this
sir.
conversion of alcohol by alcohol dehydrogenate to aldehyde, where does it take place in the hepatocyte?
Sir, it is in the cytosolic. This is cytosolic
Cytosol.
reaction.
Very good. Then the conversion of acetaldehyde to acetate by
That is in
acetate
mitochondria.
mitochondria. So what will it produce? This acetate, what will it do? If you consume normal quantity of alcohol, what will happen? If you continue heavy quantities every day, what will happen? What
Sir,
does the acetate do?
acetate will go for
It's a
glutamate synthesis.
pro-inflammatory or an anti-inflammatory agent?
It is a pro-inflammatory, sir.
It's a pro-inflammatory. So it will induce all the inflammatory cytokines. Okay, when the inflammatory cytokines are induced, which histological structure in the liver is capable of multiplying and producing a fibrotic change? Because cirrhosis is nothing but fibrosis in the liver.
Yes,
The
sir.
normal hepatocyte is lost and that is replaced by fibrous tissue.
Sir, cells of Ito, they are actually important.
And
They
stellate.
are stellate
Stellate
cells.
cells. Okay, these are the two cells. Ito cells and stellate cells are the two cells which are provoked, and they are the ones which will form the fibrous tissue, and they will convert the hepatocyte into fibrotic cells, and gradually this, what will happen to the shape of the liver?
So it will get distorted and micronodules will be formed, which will further elongate to macronodules.
It will shrink and become nodular. Okay, it will shrink rather than expanding. Initially, it may expand, there may be slight swelling, but later on, it will shrink and become nodular, and all its functions will be lost. Now, the next question they can ask you is, what are the functions of the liver? Why liver is important for us?
So, functions of liver can be divided into synthetic functions, secretory functions, detoxification, and enzyme secretion of enzymes. So biosynthetic function can be tested by using the in liver function test. Biosynthetic function test is you assessed by serum albumin and serum globulin, while serum enzymes or secretory functions, enzymatic functions are tested by alanine, aminotransferase, alanine and aspartate. While excretory or detoxification can be assessed by serum ammonia levels. And coagulation profile also is a synthetic function test. Coagulation profile will also come under synthetic function.
So, what test you will rely upon to assess the degree of damage to the liver?
Sir, means if it is an acute damage, then early coagulation profile will be deranged, and if it is a chronic damage, serum albumin level will be decreased in those cases.
Decreased. Okay. So these are considered as the prognostic or the tools to assess the degree of damage. Okay. Now, what is the architecture of the liver? Histological architecture, and why should you know that as an anesthetist?
Sir, functional unit of liver is SC9. It is a hexagonal shaped structure. In between, the central veins are present, and at the corners is portal triad. So around the portal triad means degree of necrosis or degree of ischemia can be classified according to this zone 1, zone 2, zone 3. In zone 1 and zone 3 are the area where phase 1 and phase 2 reactions generally occur.
Oh, how many descriptions are there for the architecture of the liver histologically? What are all the? There are three different descriptions. What are they? One is called the classical hepatic lobule. Okay, that is what you are describing as a hexagonal structure with a central vein with a radiating hepatocytes and all the 6 corners having the portal triad of a branch of hepatic vein, portal vein, and a biliary canaliculum. This arrangement is mainly for venous drainage from the hepatic artery, hepatic vein, along with the after they supply the blood to the hepatocytes. How is the blood supply to the individual hepatocyte subserved? Is it individual capillaries going and supplying the blood to the hepatocytes, or is it a different arrangement in liver?
Sir, no individual capillary is going to each hepatocyte. That means through portal vein and hepatic artery directly it is.
How is it? What is the structure that is there to supply? Huh?
Canaliculi. I don't know.
Not canaliculi. Sinusoids, hepatic sinusoids. Okay, it is a long tortuous vein, open vein, which is called hepatic sinusoid, and there is a small space between the row of hepatocytes and the sinusoid. What is that space called?
Space of Dcld.
Space of Dcld. Excellent. So the blood seeps through the sinusoid wall, enters the space of Dcld, and then enters the hepatic cell wall and goes into the cell to subside the nutrient, oxygen, everything is done like that. Okay. And what is the peculiarity about these sinusoids? How do they protect the liver and our entire body?
They are collapsible.
Collateral. If you want to protect something, you need some type of cell. What type of cell is there? Which cells protect
Kupffer cells.
It is a modified macrophages. Okay, Kupffer cells. So the Kupffer cells are the most important cells for immunological function to prevent any infection or anything. So if they are damaged by the repeated inflammation, then they lose their ability to protect the liver, and the inflammation stimulates the fibrotic cells like Kato cells and stellate cells, and so they replace the hepatocytes and produce fibrosis, and that is how the whole process goes on. So the classic hepatic lobule is mainly for the supply of blood and the drainage into the central vein. And there are two other descriptions. One is called the portal lobule and the other is called portal acinus. And in the portal lobule, it is a diamond shaped structure connecting the adjacent hepatocytes or the hexagonal cells, and that is mainly for bile drainage. And there is a third one called portal acinus, where it is mainly for the supply of oxygen. That is where your zone 1, zone 2, zone 3 come, and the zone 3 being far away from the hepatic artery and portal vein and very close to the central vein area. That is zone 3, which is susceptible for hypoxemia and lose its oxygen, survival at the earliest. Okay. So these three things you should remember. One is the classic hepatic lobule. Second is the portal lobule, which is mainly for biliary drainage. Third is the portal acinus, which is mainly for delineating the various zones of zone 1, zone 2, zone 3 for oxygen supply and their enzymatic function. So if zones which are away from the oxygen supply, the zone 3 will be the first one to get affected if there is a hypoxemia to the liver for any reason. Okay. So this is what you have to remember very clearly. And the third thing that they are commonly asking is about the peculiarity of the blood supply. That is a question that can be asked.
Yes, sir. So, sir, liver has a dual blood supply, sir. Means 75% of the blood supply to the liver is by portal vein, and 25% of the blood supply is by hepatic artery. But for oxygenation, 50-50 they share in array of 50-50%. Sir, auto means liver is not a organ which has its own auto regulation. So blood supply means blood supply is controlled by intrinsic and extrinsic mechanism. Means the liver extrinsic mechanism will constitute of neuronal and hormonal system, while in intrinsic, sir, hepatic artery buffer response is there. And sir, metabolic control is there with the changes of pH in carbon dioxide. And sir, third is pressure flow autoregulation. Means it is
what is the transmitter for hepatic arterial buffer response?
Adenosine.
What is the transmitter substance for hepatic arterial buffer response? What do you mean by hepatic arterial buffer response?
Sir, hepatic arterial buffer
there is a decrease in the portal
venous
vein flow. What will happen to the hepatic arterial flow?
It will increase, sir. So
it will increase. The hepatic artery will dilate and more blood will flow. Instead of the normal 25%, can increase up to what percentage it can increase?
40, 70,
40%. It can increase about almost to 40 to 45%. How is this possible? Which transmitted substance helps to dilate that vessel?
Adenosine, sir.
Adenosine, excellent. So the adenosine is the one which are all the other locations adenosine is helpful to dilate the arteries and improve the blood supply.
Coronaries.
Coronaries, yes.
Yes, sir.
But where does adenosine cause a constriction instead of vasodilatation? Only one location where adenosine causes a vasoconstriction instead of vasodilatation.
Kidney, sir.
Kidney, which part of kidney? Correct. Your answer is correct. Which part?
JG apparatus.
JG apparatus. It is the afferent vessels of the glomeruli. Okay, the pre-capillary afferent vessels, which will be constricted by adenosine and not dilated. Okay. All other areas, adenosine is a vasodilator. It dilates the hepatic artery, it dilates the coronary arteries, whereas in the pre-efferent arteries in the glomeruli, they cause vasoconstriction. So that is the only location. Right. So this hepatic arterial buffer response is another important question they ask you, which you have to be very careful about. Now, supposing this patient comes for an incidental surgery instead of this bleeding episode, he is having a hernia and he requires a herniorrhaphy. How are you going to give anesthesia for him?
Sir, I would like to give such means in herniorrhaphy, sir, we can give spinal anesthesia because we will be giving below level of T10, sir. Means I would not like to go above the level of T10 so that the reflexes means hepatic artery reflex buffer response reflex is intact and flow to the liver is intact.
See, always don't get caught in this trap. Whenever the examiner asks you about a clinical condition and asks you how you give anesthesia, always start with you do not know the status of the patient's liver condition. You have not evaluated him. Isn't it?
Yes, sir. Yes, sir.
So always say, don't get into the trap. Don't immediately jump to what anesthesia you will give. You always start saying that I will first evaluate, do the investigations, assess the risk stratification, and then plan my anesthesia. That is always safer. Don't immediately jump and say you can give even a hernia block and finish off the surgery. That is not at all a big question. But in the examination, the examiners want you to say that you are a very safe anesthetist. from that I only they are asking question. So never commit with the anesthetic technique immediately. Always say, I have to evaluate this patient. I want to do certain investigation and then assess the risk involved and then plan my anesthesia. So
Okay,
coming to that point, how are you going to evaluate this patient? What are all the investigations you want to do? How do you classify the risk involved in this patient?
So, sir, patient for herniorrhaphy means after adequate history, I will go ahead with the blood investigations like hemoglobin, means complete blood count, including hemoglobin, total count, differential count, platelet count. Then coming on to liver function tests, serum bilirubin, SGOT, AST, ALT, serum albumin, coagulation profile. Then moving it to renal function tests. Renal function test would include serum urea, serum creatinine, serum electrolytes, then PTINR means coagulation profile. Then, sir, moving ahead, a baseline ECG, baseline chest X-ray.
Go ahead. So you have done all the investigations. Investigation results have come. How are you going to classify the risk or stratify the risk?
So, risk stratification in CLD patient can be done by child pug and child torqued pug scoring. In that, for 5 criteria are there, including serum bilirubin, serum albumin, TINR, hepatic encephalopathy, and ascites.
Okay, based on this, how many groups will be there?
So there are three groups are there, sir, which will give us the prognosis of the case
Okay.
on a year basis, mortality on 1 year and 2 year basis, sir.
Okay. Group A, Group B, Group C. Group A is considered almost a normal patient. Group B and C are moderate and severe patients. Okay, where the morbidity and mortality is quite high. What is this CPT scoring replaced by? Is it
Sir?
used in all cases or it is not considered in certain cases?
The CPT scoring nowadays is not being considered for liver transplant and all means, because it is a
Okay.
very subjective sort of scoring. Means,
Very
because
good. Excellent. Okay. So what is the modification done and what is the current scoring system used for liver transplant patients?
MELD score, sir, model for
Very good.
end-stage liver
So
disease.
what are the criteria taken into MELD scoring? Even if you are not able to say the exact the decimal points with which you have to multiply the parameters, what are the 3 important parameters used for MELD scoring?
Sir, serum bilirubin, serum creatinine, and PTINR, sir.
PTINR. Okay, very good. What is ALB score?
Sorry, sir.
Have you heard of ALB score? ALBI. ALB score.
No, sir.
Have you heard of Adopt LC score? Ravitra? Ammu? Anybody who has heard about ALB score and Adopt LC score? Okay, so
LB score is for hepatocellular carcinoma.
hepatocellular carcinoma, excellent. And uses which parameters?
And it uses serum albumin levels.
And
And the
bilirubin. Very good.
bilirubin.
Next, who is answering that?
Prof.
Pavitra, are you answering? Very good. Okay, correct. You are right. ALB score is nothing but AL stands for albumin, BI stands for bilirubin, and that is a score which is used for mainly to assess the morbidity and mortality in patients suffering from hepatocellular carcinoma. Whereas Adopt LC score is a score adequate operative treatment for liver cirrhosis. That is the expansion for the acronym Adopt LC. Okay, that again uses 4 parameters: the age of the patient, CPT scoring, Charlson's comorbidity, and then there is a fourth one. Four criteria are used to calculate that, which again assesses the morbidity and mortality. So based on the investigation findings, you can now stratify the risk and then plan your anesthesia. And if the patient is belonging to the CPT A group, that means he is almost a normal patient with no coagulopathy or no other answers. Why we are worried about this stratification? What do we want to avoid in a patient with chronic liver disease? What do we want to avoid?
I can get to the end.
We want to avoid acute on chronic. We want to avoid an acute liver failure on chronic liver disease patient. So based on the time duration, how do you classify liver failure? There are
Acute,
three
hyperacute,
categories.
and chronic. Acute, hyperacute, and chronic. Sir.
It is chronic, acute on chronic, and acute. Okay. So these are, of course, in acute you have hyperacute, but the three categories are chronic liver disease, acute on chronic liver disease, and the third category is acute liver disease, where there is a subacute, where the duration of encephalopathy is very short. We call it as hyperacute. So the main three categories are chronic, acute on chronic, and acute liver disease or liver failure. Okay, so we want to avoid an acute liver failure. What is the main reason for the acute liver failure? Why the encephalopathy occurs?
Serum ammonia means suddenly rise in the serum ammonia level because of unable to convert that to keratin.
So in what way ammonia is eliminated in the body, and in what way the liver helps to do that?
So by ornithine means by ornithine
Converts
cycle.
ammonia into urea. That is the answer. Okay, it converts ammonia into urea with the help of utilizing what?
Enzyme. Okay.
What is the other ingredient required to convert ammonia into urea? What is the other ingredient added to urea? I mean ammonia to make it urea. Carbon dioxide in the form of bicarbonate. So urea or ornithine cycle. Please read that and keep all the steps in mind so that suddenly they may ask you. So once your ammonia is converted into urea, urea is water soluble and goes out into the urine. Okay, that is the main reason. If liver function is damaged, then this cycle will not happen and ammonia will accumulate, and this hyperammonemia is the main cause of encephalopathy. Right? So
Yes,
how
sir.
do you manage a patient with liver failure? What is the treatment that you should adopt? If this patient has got, say, CPT-B group, he has got mild encephalopathy is there, he has got deranged INR, his albumin is low, and he requires a herniorrhaphy. How are you going to manage this patient?
So preoperatively, sir, protein diet restriction,
Very good.
giving lactulose, giving antibiotics like rifaximin, neomycin, using probiotics, sir.
What about aldosterone antagonist? Now we have
For
got abdominal
diuresis.
distension, edema is there, isn't it?
Yes, sir, diuresis.
So please remember all the steps in the management of liver failure. Okay, starting from correcting the encephalopathy by restricting the protein intake, and then decontamination of the gut, then antibiotic, that neomycin, and then aldosterone and albumin correction if necessary by transfusion of albumin. So, and correction of coagulation
Vitamin.
by vitamin K. So these 5 things you should remember and be able to tell in the examination. Okay. Now, lastly, before closing, if supposing nowadays liver transplant is being done in so many centers, so the examiners might like to find out what is your knowledge on that. So if this patient has gone on to end-stage liver disease and he requires a liver transplant, how are you going to anesthetize this patient?
Sir, after adequate evaluation and after optimizing the patient, preparing all the emergency drugs and
What are all the types of liver transplant you know? Always when a transplant question is asked, there are different types of transplant. One is that there may be a live donor or there may be a deceased donor, brain dead or a deceased donor. Isn't it?
yes, sir.
So in live donor, what is the challenge? In deceased donor, what is the challenge or the difference? Live donor means a compatible, just like a renal transplant. You have to have the compatibility, but not so strict like that. And the donor should be assessed, and they can donate their right or left lobe based on the need and the size of the recipient. So one basic question they can ask you is, how do they decide whether to take the right portion or the left portion of the liver in a live donor transplantation? What is the criteria? Which segments of the liver are taken out if you plan for a right hepatectomy? Which segments of the liver are taken out if you take a left?
Sorry, sir. Sorry, sir.
So the segments, all these things you should have a knowledge, because nowadays, you know, liver transplant is being done in so many centers. So examiners earlier, they used to excuse the students, even if they are not able to answer this. But now with the advent of liver transplant being done in many centers, maybe after you pass out, you may get a job in a liver transplant unit yourself. So it is better you have at least some basic knowledge. So the liver segments are classified in two ways. One is based on the hepatic venous drainage area, another is the portal vein branch area. So there are two different classifications, but totally it is divided into 8 segments. And these 8 segments, the 5, 6, 7, 8, they are on the right side, 1, 2, 3, 4 are on the left side. So depending upon the recipient size and the abdominal cavity, they decide right side will be a bigger segment, whereas left side will be a smaller segment. So if it is the patient's abdominal cavity is small because of the small BMI, then they choose the left. And especially for a pediatric, they choose the left, which is sufficient. What is the basic concept in liver transplant? You are taking only a small portion and keeping, unless a kidney transplant where you are removing a full kidney and then placing it in the abdomen. You are taking only a small portion. So what way that transplanted liver helps to function as a
Regeneration.
regenerating capacity? Excellent. It regenerates by quick mitosis. 70% of regeneration can happen both in the donor as well as in the recipient. That is the beauty of liver transplant. So once you give a compatible liver portion, then it can grow and it can occupy, almost become like a normal cell. So that much of regeneration capacity is there. So the basic things about liver transplant, you have to know that the challenges are pre-hepatic, hepatic, and hepatic. That is how it is classified. The anesthetic challenges are classified into the pre-hepatic, where it is mainly the dissection. What are the surgical, anesthetic requirements during the dissection phase? Do you have to keep the blood pressure high or low?
Better on the lower side to infuse.
Lower side, infuse low so that the IVC is not very dilated and scourgeous. So keep a volume low, keep the blood pressure low to avoid extensive blood loss, because that is the stage they will lose a lot of blood. Then the anhepatic stage, when they clamp the vessel and remove the deceased liver. This is an orthotopic transplant, that you have to keep the donor liver in the same position, unlike the kidney where you keep it in the retroperitoneal area away from the normal kidneys. This is a same position transplantation, which is called orthotopic. So you have to dissect that area and clear it. Then for a few time, there is no liver function at all. And then once the anastomosis is released and then when the clamp release is done, there is a reperfusion injury possibility. So these are the challenges. So a lot of electrolyte imbalance, hypothermia, and blood loss. These are the challenges. So earlier they used to have rapid transfusion facilities, the rapid transfusers, level 1, level 2 transfusers, they're all used. Nowadays, the technique is advanced, so they are able to manage with not much of blood requirement and complete the surgery. So at least read about the basic requirements for a liver transplant, and that will be the common questions that will be asked. So I'll just share a small presentation with you.